Esophageal perforation. A tear, a rupture, a hole in the delicate lining of the esophagus. It sounds dramatic, and it certainly can be. In this video, we'll delve into the complexities of this serious condition, exploring its causes, symptoms, diagnosis, and treatment options. So, what exactly causes the esophagus to rupture? The most common culprit is iatrogenic injury. This means it's caused by a medical procedure, often an endoscopy or dilation. These procedures, while generally safe, can sometimes inadvertently damage the esophageal wall. Other causes include forceful vomiting, especially in cases of Boerhaave syndrome, swallowing a foreign object, like a bone or a sharp piece of plastic, trauma to the chest or neck, esophageal cancer, and rarely spontaneous rupture. Let's get into the pathophysiology. When the esophagus perforates, the contents of the esophagus, saliva, food, and stomach acid leak into the surrounding tissues, most commonly the mediastinum, which is the space between the lungs. This contamination leads to a severe inflammatory response. The body's immune system goes into overdrive, attempting to fight off the infection. This inflammation can rapidly progress to sepsis, a life-threatening condition. Additionally, the pressure from the leaked contents can compress vital structures in the chest, such as the heart and lungs, further compromising their function. Esophageal perforation is a relatively rare condition. Iatrogenic perforations, due to procedures, are the most common type. Boerhaave syndrome, caused by forceful vomiting, is less frequent. While the exact incidence varies depending on the population studied and the availability of diagnostic tools, it's important to remember that early diagnosis and treatment are crucial for improving outcomes. The signs and symptoms of esophageal perforation can vary depending on the location and size of the perforation, as well as the underlying cause. However, some common indicators include sudden, severe chest pain, often described as sharp or tearing. Pain can also be felt in the neck or abdomen. Other symptoms may include difficulty swallowing or pain with swallowing, shortness of breath, fever, hoarseness, and subcutaneous emphysema, which is air trapped under the skin, causing a crackling sensation when touched. Diagnosing esophageal perforation requires a high index of suspicion, especially in patients presenting with the aforementioned symptoms. A contrast esophagogram, where a special dye is swallowed and then X-rays are taken, is often the initial diagnostic test. This can help identify the location and size of the perforation. A CT scan of the chest and abdomen can further define the extent of the perforation and identify any associated complications, such as mediastinitis or abscess formation. Endoscopy may be used, but cautiously, as it could potentially worsen the perforation. While not strictly categorized into distinct types, esophageal perforations can be classified based on their location as cervical, thoracic, or abdominal, the mechanism of injury iatrogenic, spontaneous, traumatic, etc., and the time elapsed since the perforation occurred. The timing is particularly important, as delayed diagnosis can significantly worsen the prognosis. A chronic perforation, one that has been present for a longer duration, may have different treatment considerations than an acute one. Treatment for esophageal perforation is complex and depends on several factors, including the size and location of the perforation, the underlying cause, the patient's overall health, and the time elapsed since the perforation occurred. Treatment options range from conservative management to surgical intervention. Conservative management may include nothing by mouth, intravenous fluids and antibiotics, and endoscopic stenting to seal the perforation. Surgical repair is often necessary for larger perforations, those that are not amenable to stenting, or those associated with significant contamination. The surgical approach may involve primary repair of the perforation, esophageal resection, or diversion procedures. Preventing esophageal perforation primarily focuses on minimizing the risk of iatrogenic injury during endoscopic procedures. This involves careful technique, proper training of endoscopists, and appropriate patient selection. In cases of forceful vomiting, such as in Boerhaave syndrome, prompt medical attention to address the underlying cause can help prevent complete esophageal rupture. Avoiding swallowing foreign objects, especially sharp ones, is also a key preventive measure. The prognosis for esophageal perforation depends heavily on the speed of diagnosis and treatment. Early diagnosis and prompt intervention significantly improve the chances of survival. Delays in diagnosis can lead to severe complications, such as sepsis and mediastinitis, which can be life-threatening. Recent research is focusing on improving endoscopic techniques to minimize iatrogenic injuries, developing new stent designs for more effective closure of perforations, and exploring novel antibiotic regimens to combat the resulting infections. Furthermore, advancements in minimally invasive surgical approaches are offering less invasive options for repairing esophageal perforations, leading to faster recovery times and improved patient outcomes.